The advertising messages in this episode are brought to you by Breast Cancer Index, the first and only test recognized by professional oncology guidelines to predict benefit from extended endocrine therapy in early-stage hormone receptor-positive breast cancer. Can you identify the 95% of women who don't benefit from extending anti-estrogen therapy from 5 to 10 years? Breast Cancer Index can help. To learn more, visit breastcancerindex.com/ONS. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by ONS member Marianne Davies, nurse practitioner at the Smilow Cancer Center in the Yale Comprehensive Cancer Center and associate professor at Yale University's School of Nursing, both in New Haven, Connecticut, and member of the Central Connecticut ONS chapter, to discuss how oncology nurses can safely administer Pembrolizumab immunotherapy and manage its associated adverse events. This episode is part of an ongoing series about outpatient oncology drug infusion. The other episodes are linked in the episode notes. The advertising messages in this episode are paid for by Breast Cancer Index. Thanks for joining me today, Marianne.
Well, thank you for having me.
So to start us off, can you give us some background on Pembrolizumab?
Certainly. So the role of the immune system in cancer has been studied for decades. In 2010, the concept of the cancer immune cycle was formulated. The study of T cells identified several inhibitory and stimulatory checkpoints that either turn on or turn off the function of the T cell. While several of these have been identified, it was not until the 1980s that blocking CTLA-4 led to cancer cell death. The first checkpoint identified was CTLA-4 in 1980s, and the second inhibitory signal was PD-1. Pembrolizumab is a PD-1 inhibitor. It's a humanized antibody used in cancer immunotherapy. It's an antibody that blocks a protective mechanism of cancer cells and thereby allows the immune system to destroy them. It targets the programmed cell death protein PD-1 receptor on lymphocytes. It works by targeting the cellular pathway of proteins found in the body's immune cells and some cancer cells, known as PD-1 or PD-L1. Pembrolizumab was first developed in 2006 and received its first approval for medical use in the United States in 2014.
Well, thank you for that introduction. Can you talk about what the drug's mechanism of action is?
Sure. So to expand on our first statement, the immune system is the body's natural defense mechanism. Its purpose is to protect the body and keep it healthy. One of the ways it does this is by detecting and eliminating harmful substances such as bacteria, viruses, and cancer cells. When the immune system recognizes a foreign substance, an antigen, it creates antibodies to either attack and fight infection or cancer directly, or to call up other proteins or cells such as T cells or T lymphocytes. These are to destroy the antigen. Antibodies stay in the body so that the immune system can more easily recognize and fight that antigen if it encounters it again in the future. T cells play a pivotal role in cell-mediated tumor immunity through a carefully orchestrated balance of stimulatory and inhibitory signals between mediators of the immune system. Pembrolizumab is a therapeutic antibody that binds to and blocks PD-1 located on lymphocytes. This receptor is responsible for preventing or inhibiting the immune system from attacking the body's own tissues. So it is called an immune checkpoint. Normally, the PD-1 receptor on activated T cells binds to the PD-L1 or PD-L2 ligands present on most normal cells in the body, deactivating any potential cell-mediated responses against these cells, hence preventing autoimmune attack. Many cancers make proteins such as PD-L1 that also binds to the PD-1 receptor, thus shutting down the ability of the body to kill the cancer cells. The cancer evades the surveillance of the body's immune system. Pembrolizumab works by inhibiting lymphocytes' PD-1 receptors, blocking the ligands that would deactivate it and prevent an immune response. This allows the immune system to target and destroy cancer cells, but also blocks a key mechanism preventing the immune system from attacking the body itself. This checkpoint inhibitor function thus has some immune dysfunction side effects. They resemble autoimmune disorders.
It's so interesting how the new medications that are being made available for patients are so specific, like you've just explained, going down to that cell level and being able to turn things on and off and make the body be able to recognize the cancer cells as well as, keep it from not harming the healthy cells in the body, versus our old types of chemotherapy where it was just kind of like you gave it and it went to and affected any cell in a certain cell phase during its cell cycle. So it's just really neat to hear about how these new drugs are working and how they can be used.
Yes, it is fascinating.
What types of cancers and diagnoses is pembrolizumab used to treat?
Pembrolizumab is approved for several solid malignancies, hematologic malignancies, and tumor-agnostic malignancies. By this, we mean tumors that have certain genetic anomalies. The first two approvals for pembrolizumab were in the treatment of melanoma and non-small cell lung cancer. It now has approvals in head and neck squamous cell carcinoma, classic Hodgkin's lymphoma, primary mediastinal large B-cell lymphoma, urothelial carcinoma, microsatellite instability high or mismatch repair deficient cancers, MSI high or MMRD colorectal cancer, gastric, esophageal, cervical, hepatocellular, Merkel cell, renal cell, endometrial, cutaneous squamous cell carcinoma, triple-negative breast cancer, and tumor mutation burden high cancers. Some of those indications will require the presence of positive PD-L1 expression or tumor mutation burden high when one is analyzing the pathology of the tumor. And the dosing of the pembrolizumab is IV administration either every 3 or 6 weeks. For some cancers, it may be administered in combination with chemotherapy or with oral targeted therapies.
So does this drug have any black box warnings?
There are no black box warnings. However, there are warnings and precautions. For patients that may have previously received an allogeneic hematopoietic stem cell transplant, there is a risk of fatal or serious complications that can occur before or after immune checkpoint inhibitor therapy. This can include an increase in graft versus host disease, veno-occlusive disease, and even the loss of the stem cell graft. For people that have had prior organ transplants, there is a risk that unleashing the body's immune system may cause failure of that organ transplant. So in essence, those patients may lose the graft. There's also a risk for a flare of prior autoimmune diseases. So one needs to be very well informed if one has these histories, past medical histories, to make an informed decision about whether to receive this as a treatment. Another concern is persons that are on corticosteroids or on immunosuppressants. If possible, these should be discontinued prior to the start of pembrolizumab. If the patient requires these agents for other autoimmune diseases or transplant, and they are not able to be tapered off, then they are likely not a good candidate for treatment with pembrolizumab.
So in your answer, you mentioned patients who have had transplants, be that stem cell transplants or organ transplants. What do these black box warnings mean for administration and post-administration care?
Again, these are not necessarily black box warnings, but they are very significant warnings. What it means is that if a patient had previously received either a stem cell transplant or organ transplant, most likely they're going to be on immunosuppressant therapy that allows their body's immune system to accept the transplant and accept that organ. So if one is on high doses of immunosuppressant therapy, it's going to shut down the effect of pembrolizumab, making it inactive. So it would not be a good therapeutic. In some cases, patients can have steroids or immunosuppressant medications tapered down to low doses. And in that case, they may possibly be able to receive pembrolizumab. Again, there is a concern, though, that the graft can be lost. So it's really important to have informed consent for these patients so they understand the risks and benefits. So for instance, if the patient, let's say, had a kidney transplant in the past, and they have a very aggressive cancer that might respond to the pembrolizumab, the providers and the patient and family may elect to take that risk because there's at least an alternative therapy if the kidney graft is lost. That patient can go on to receive dialysis. However, if a patient had previously received, let's say, a cardiac transplant, there is really not another option. So it would be definitely contraindicated in those patients.
Well, that's definitely something that nurses who have not administered this treatment before really need to be aware of. And I think with, our patient population, there's that chance that they may have had treatment or had a transplant in the past. But the other thing too is just, with patients moving across state lines and across the country, it's so important to know the kinds of things to ask whenever we're administering these types of medications. You mentioned early on when you were talking about the drug's mechanism of action, the immune-related responses. So what side effects and adverse events are commonly associated with pembrolizumab, and how can oncology nurses manage these concerns?
Great question. Oncology nurses really are at the forefront of evaluating these potential toxicities of therapy. And so it's important that they are very well versed in what to assess for. So the novel mechanism of action of checkpoint inhibitors involves the enhancement of the immune surveillance, which also exposes patients to unique immune-related adverse events, or we also often use the acronym IRAEs. By enhancing the patient's immune system, immune checkpoint inhibitors also increase the risk of inflammatory side effects. When immune checkpoint proteins are inhibited, there is a risk that the immune system will be released to attack some healthy as well as tumor cells. That is, produce an autoimmune reaction, or IRAE. Side effects can be inflammation of any organ system in the body. They may occur independently in only one organ system, or it can occur in multiple organ systems at one time. If the lungs are inflamed, this is called pneumonitis. Patients will have shortness of breath and may require oxygen. Skin reactions include rash and pruritus. The gastrointestinal tract includes diarrhea and risk of colitis or perforation. Kidney inflammation is nephritis. One might see an elevation in BUN and creatinine. Liver toxicity includes an elevation of liver enzymes. Neurologic toxicities include peripheral neuropathy, myasthenia gravis, Guillain-Barré syndrome. The eyes becoming inflamed can lead to uveitis, iritis, and scleritis. Pancreatic inflammation, one may note an elevation of lipase, pancreatitis, or type 1 diabetes. So these are some examples, but keep in mind any organ system can be involved, and there's not necessarily a way to predict which system will become inflamed or at what period of time, though there are guidelines that can help us to assess typically when these occur. Typically, the side effects or the IRAEs are low grade, meaning they're minor in severity. However, if left unmanaged, they can become serious and even life-threatening. The important thing for nurses to do is to educate patients about all of the possible side effects and the presenting symptoms. Patients should be encouraged to contact the team immediately of all new or progressing symptoms, because the sooner a side effect is identified, the better the likelihood that it can be managed with minimal intervention. So delays in identifying an IRAE can possibly lead to progression of the IRAE. And as mentioned, it can be serious or fatal. Typically, the way that we manage these toxicities is by administering a course of steroids. And I know that might sound counterproductive when I talked about patients being on steroids before, but the steroids are a way to suppress the body's immune system so it stops attacking itself. And typically, patients only need a short course of the steroids to get the toxicity under control. And if that steroid is tapered off securely and the toxicity is resolved, many times patients can go on to be re-challenged with the pembrolizumab. Another important thing is that nurses should encourage patients to carry a wallet card, which has the name of the healthcare team, identifying which medication the patient is receiving, because sometimes patients may develop side effects and present to other facilities other than our own cancer centers. They may present to an emergency department, an outside hospital, or an urgent care center. And it's important that patients and families partner with us to help educate other healthcare professionals about the treatment they are receiving and the potential toxicities.
Thank you. I think it's really important for nurses to understand and know what those toxicities are upfront so that, they know to ask the patients when they come back in or if the patients are calling in, and really to be able to ask and see if those patients are experiencing any of those side effects or IRAEs, as you mentioned. The advertising messages in this episode are brought to you by Breast Cancer Index. Joint pain and hot flashes, mood swings and weight gain. Breast cancer patients on anti-estrogen therapy know all about the side effects, which is why the decision of whether to stop therapy at 5 years or to continue through 10 is so vital for so many women. Breast Cancer Index is the guideline-recognized genomic assay for evaluating the duration of anti-estrogen therapy, a modern predictive tool that removes the guesswork, validates decision-making, and improves patient compliance. Breast Cancer Index, the modern guideline for extended endocrine therapy. So, as a checkpoint inhibitor, pembrolizumab may cause IRAEs, like you said, and toxicities. In our ONS Communities thread, a member asked us about laboratory parameters for side effects such as endocrinopathies. What do established guidelines recommend when monitoring for IRAEs?
So, all of the established guidelines for managing and assessing IRAEs mention that patients prior to the start of therapy should have baseline labs done to assess baseline organ function. This includes a complete blood count, complete metabolic panel, glucose, which includes glucose, electrolytes, kidney function, and liver function, a baseline amylase and lipase, a baseline TSH or thyroid stimulating hormone, and free thyroxine or T4. The T4 and TSH should be assessed every 4 to 6 weeks while on immune checkpoint therapy, and then every 12 weeks if indicated. There should be a baseline EKG. Additional labs are suggested but not mandatory. These include CK, inflammatory markers such as ESR and CRP. For evaluating potential colitis, it's a calprotectin or lactoferrin. To assess pituitary and adrenal function, there's serum cortisol in the morning, luteinizing hormone, FSH, testosterone, estradiol, and ACTH. And if there's a concern for cardiac dysfunction, cardiac biomarkers such as troponin I or T, creatinine kinase, BNP, or NT-proBNP. Typically, the standard blood work, including a CBC, CMP, and thyroid function, are done prior to each administration. The other specialty labs can be done if there is consideration that the patient is developing a toxicity of that specific organ system.
Thank you. Again, lots to know about these medications, especially for new nurses, or actually not even just new nurses, but nurses who haven't ever, administered this before. So are there any contraindications to using pembrolizumab?
So we highlighted some of the warnings earlier on, but I want to just raise the point again that if patients do have a prior underlying autoimmune disease that requires steroids or immunosuppressant therapy, they would likely not benefit significantly from pembrolizumab or other immune checkpoint inhibitors. In fact, it could cause a severe flare of the symptoms. Another consideration is that if a patient has had a grade 3 or grade 4 serious life-threatening immune-related toxicity from another immune checkpoint inhibitor or from the pembrolizumab, they will be at high risk of having the same IRAE, which can be serious or fatal. So one must use caution when one's making a decision about re-challenge with immune checkpoint therapy.
So I'm going to ask you a question about you presented at the ONS Congress in April 2021. And you mentioned pembrolizumab is often used in combination with other drugs. Do combination therapies change any of these nursing considerations for administration or patient management that we've already mentioned in our discussion today?
So patients on combination therapies can be challenging. There are approvals for combination immune checkpoint inhibitors across disease types. These include combinations with chemotherapy, targeted therapy, and anti-angiogenic agents. Pembrolizumab has approvals with chemotherapy in lung cancer, head and neck squamous cell carcinoma, gastric, esophageal, and breast cancer, and in combination with lenvatinib, a TKI for endometrial cancer. The landscape for combinations is always changing with new approvals expanding, so it does require refreshing your memory when looking up pembrolizumab and other immune checkpoint therapies, which is really exciting that we're having increasing new combinations that we can offer to patients. There may be overlapping toxicities, however, with combining these agents. It's important to assess for the contribution of each agent in the development of the toxicity. Consider each drug independently. The timing of onset can be important. There may be additional immune markers that will be assessed to determine if a side effect is due to immune attack or if it's due to another drug reaction. The full multidisciplinary team will be important in evaluating the cause and managing the toxicity. This may include holding therapy for a period of time while other diagnostics are obtained. It's important that nurses provide supportive care and assurance to patients at this time. We need to keep in mind that there is a delicate balance between therapeutic benefit of cancer treatments and its side effects.
It is really exciting that these medications can be used in combination, and just the outcomes that we're seeing with being able to add immunotherapies to traditional treatments as well as just, in combination. And it is exciting, but it definitely, as you mentioned, can also add some things that need to be considered. So now let's talk about patient education and what should an oncology nurse provide before administering this?
So patients should be educated about the mechanism of action of pembrolizumab, as this really serves as a basis for the rationale for potential side effects. Nurses should review the signs and symptoms of all potential toxicities and the parameters for which a patient should report to the treating team. As stated, most IRAEs are low grade or minor in nature. However, if unmanaged, can be life-threatening. Patients should understand their schedule of administration, which may vary if they're receiving single-agent therapy or combination. It's important to set expectations about the response to therapy. This is particularly important if a patient has received prior therapy. By this, I mean that sometimes with immune checkpoint therapy or pembrolizumab therapy, it may take several weeks or even a few months before a response can be noted on a CAT scan. This is a little different than cytotoxic chemotherapy agents, in which we might receive a response on CAT scans earlier on. So again, sometimes there are delays in response to treatment as the body's immune system is activated. Another point is that patients of childbearing years should be advised to use effective birth control during and for at least 5 months after the initial dose of immunotherapy, and breastfeeding is contraindicated. Patients should carry the wallet card with contact numbers and the types of immunotherapy they're receiving. Nurses should particularly educate patients about the use of corticosteroids. Patients should not start any corticosteroids until they discuss this with the treating oncology team. If a patient must start corticosteroids for immune-related adverse events, they will need to be educated on how to take those corticosteroids and the use of supporting interventions to help prevent side effects from the steroids. So this will include an H2 inhibitor to prevent gastritis and monitoring of blood glucose. If patients are on prolonged courses of steroids, they will need vitamin D and calcium supplements to minimize osteoporosis, and prophylaxis against PJP, fungal infections, and herpes zoster reactivation.
Well, Marianne, you've given us a lot of excellent information today about pembrolizumab and what nurses need to know when they have patients who are receiving it. So I want to, first of all, thank you for just your expertise and the information that you've provided for us. And as we are finishing up, there are some questions that I like to end all of our podcasts on. And I just want to kind of go through those quick fire with you. What are some common misconceptions about pembrolizumab?
Well, patients often watch a lot of TV and they see commercials and they make an assumption that every patient is going to benefit from pembrolizumab or other immune checkpoint inhibitors. And it's important that we understand that not all patients are candidates for treatment with pembrolizumab. There are a subset of patients that may achieve a good response. However, not all patients will get the same benefit.
What's something about pembrolizumab that's not often discussed, but you wish people knew more about?
So one of the important things is that unlike cytotoxic chemotherapy, some of the effects, the immune-related adverse events from pembrolizumab can be latent, meaning they can occur even after the discontinuation of treatment and even months to years after. And so we need to be very vigilant in our assessment of patients and making sure we're communicating with their other healthcare providers to monitor for the potential of the onset of these in the months and years even following as they're going into survivorship.
What additional training or education do oncology nurses need to administer pembrolizumab?
Well, oncology nurses should regularly attend chemotherapy and immunotherapy certification course to be sure that they keep up to date on any new data that emerges about pembrolizumab and other therapies, and as more combination checkpoint therapies and chemotherapy are approved. It's important to understand the nuances of the administration and dosing schedules, as those may change with time as well.
And lastly, what are some resources for patients and providers who want to learn more about pembrolizumab?
All right, great question. There are several published clinical practice guidelines that are available for providers and nurses. The ONS Chemotherapy Immunotherapy book, the National Comprehensive Cancer Network Clinical Practice Guidelines, the American Society of Clinical Oncology Clinical Practice Guidelines, Society for Immunotherapy and Cancer. There are pocket cards and an online app and educational resources for nurses. AIM with immunotherapy, on that website, there are several educational resources, including handouts and videos to educate providers. Patient resources include that from the Society of Immunotherapy and Cancer, which is an Understanding Immunotherapy book, which you can download for free online. Cancer.net has the ASCO teaching tool. ONS has a teaching pamphlet, and you'll see many educational resources that you can download.
Marianne, as I mentioned before, I just want to thank you for being with us today and for all of the information that you provided. This is such a valuable discussion and podcast for nurses, especially as we have new oncology nurses coming in to starting their career, as well as oncology nurses who have been in practice, but now they're whether they move to a new area or this is just a new treatment that they will be administering, and really need to know and understand the nuances with pembrolizumab. So I really appreciate the time that you've taken today to give us this information. Do you have any final comments for us?
Well, this is a very exciting time, as you mentioned. Immune checkpoint therapy has changed the treatment landscape for many cancers, improving overall survival and quality of life. Oncology nurses are a critical link in managing patients on immune checkpoint inhibitor therapy.
Well, thank you so much for being with us today and for taking the time out to help educate our oncology nurses.
Oh, it's my pleasure. Thank you for having me.
The advertising messages in this episode were brought to you by Breast Cancer Index, the only guideline-recognized test for extended endocrine therapy. Go beyond traditional clinicopathologic factors with the only tool validated to inform decisions about extending anti-estrogen therapy from 5 to 10 years. When 95% don't benefit from extending, 100% of women deserve to know. To learn more, visit breastcancerindex.com/ONS. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.